Okay, Assalamualaikum warahmatullahi wabarakatuh. So there's 21 of you. 20. How many there should be in the group?
24 ada.
24. Okay, so there's only 20. Yang lain coming ke? Ke ada problem apa?
On the way ada.
On the way. Okay, alright. But we shouldn't punish those who are on time, yeah. Okay, let's. So kita tengok macam mana. I'm hoping we able to finish the 2 lectures tonight. Kalau tak, how many more? I hope we can finish tonight lah. Okay, alright. Let me share my slide. Okay, can you see my screen? Boleh nampak slide tak?
Yes, doctor.
Boleh nampak kan?
Yes, doctor.
Boleh, Doktor.
Great, super. Let me try and adjust things. Sorry, yeah. Apa nak buat ni? Okay. Okay, alright. So we'll begin with the topic of birth asphyxia first. Okay, dulu kita dah pernah discuss about the previous lecture tu, kita discuss about apa nama, topik you discuss about adaptation to extrauterine life kan. So there's a lot of correlation between the previous lecture dengan this bit of the lecture. Okay, what are the objectives? So basically, I want you to understand the keyword important in regards to birth asphyxia, know and the causes and the risk factors, understand the pathophysiology, and know the presentations and complications of birth asphyxia, and most important is you understand the managements when you have a patient with birth asphyxia. So there are several definitions that you should understand. So what is perinatal asphyxia? So perinatal asphyxia means a condition of impaired gas exchange. So asphyxia refers to gas exchange, or inadequate asphyxia refers to inadequate oxygenation. So impaired gas exchange or inadequate blood flow that leads to persistent hypoxemia and hypercarbia that occurs in temporal proximity to labor. It occurs peripartum and also intrapartum. So peripartum means antenatal, so antepartum and postpartum, and also the intrapartum period. Hypoxemia refers to abnormally low blood oxygen level. So hypoxemia, low oxygen in the blood. Hypoxia, low oxygen in the tissue. Ischemia refers to reduction or complete cessation of blood flow to an organ. So they comprise oxygen delivery and also substrate delivery to any organ. So ischemia means reduction in the low oxygen in blood, hypoxemia. Low oxygen in tissue is hypoxia. Low oxygen in organ is basically ischemia. So neonatal, when we talk about HIE, there's several elements. The first one is, what is neonatal encephalopathy? Neonatal encephalopathy is a clinical syndrome of disturbed neurological function. So there's element of encephalopathy caused by failure to make successful transition to extrauterine gaseous exchange. So this is neonatal encephalopathy. It may manifest with difficulty in spontaneous breathing, depressed muscle tone, hypotonia, poor muscle tone, and poor reflexes. Dia tak ada Morose reflex, tak ada all the sucking reflex and so on and so forth. They may be depressed conscious level, altered conscious level, and sometimes can result in seizure. So this is neonatal encephalopathy. Hypoxic ischemic encephalopathy, in a way, is encephalopathy. It's a type of neonatal encephalopathy that manifests following disruption of cerebral blood flow in term or near term infant. So Okay, so this is a huge subset. This is a huge HIE. Okay, macam ni. Neonatal encephalopathy is an umbrella term. Bawah neonatal encephalopathy ni dia ada hypoxic ischemic encephalopathy, where the encephalopathy is a result of hypoxic ischemic insult. Basically happens in a term or near term infant. Premature baby kita tak consider as HIE. So neonatal encephalopathy, larger umbrella term, bawah dia ada hypoxic ischemic encephalopathy. And bawah hypoxic ischemic encephalopathy ni ada perinatal punya perinatal encephalopathy, ada perinatal asphyxia. So perinatal asphyxia refers to intrapartum hypoxic ischemic insult that may result in all the problems. So neonatal encephalopathy ni dia broader, dia ada banyak lagi benda yang di cover, not just hypoxic ischemic encephalopathy. So moderate or severe neonatal encephalopathy occurs in 2 in 1,000 live birth. So generally term infant. Okay, so kalau kita sure it is hypoxic ischemic, then kita label as hypoxic ischemic encephalopathy. Kalau tak sure, then kita letak as neonatal encephalopathy. Sebab neonatal encephalopathy ni, as I said before, is an umbrella term. Dia cover macam-macam, CNS malformation, intracranial hemorrhage, infection, cerebral infarction, stroke, bla bla bla. So ada macam-macam elemen, macam-macam cause yang boleh result in neonatal encephalopathy. So what happens? So what we're going to talk now is mainly hypoxic ischemic encephalopathy, because I think that is the most common that you will encounter nanti, and in terms of medical legal pun, it is the most important lah. Okay, so what happens in a hypoxic ischemic encephalopathy? So contohnya kalau ada hypoxic ischemic insult. Apa hypoxic ischemic insult tu? Contohnya apa? Contohnya macam abruptio placenta. So abruptio placenta. So ada bleeding, so there'll be reduced blood flow to the baby, there'll be impact cerebral blood flow to the baby's brain and causing hypoxic ischemic insult. Ataupun contohnya apa? Macam cord prolapse. Kan, cord prolapse, prolonged second stage, apa lagi? So there's so many other problems yang boleh result in hypoxic ischemic insult in a baby. Ataupun baby tu at birth dia ada huge mass, huge tumor. Contohnya dia ada dia ada huge mass, ataupun dia punya airway dia obstructed. So airway obstruction causing hypoxic ischemic insult in a baby. So all this can result in hypoxic ischemic encephalopathy. So dia mesti ada an episode that causes hypoxia. So bila ada prolonged episode of hypoxia, that is the event. Hypoxia, prolonged hypoxia result in ischemia, and ischemia results in acidosis. So that's the effect. And the outcome is cellular death and organ damage. So in a nutshell, first ada insult, hypoxic insult. So this hypoxic insult results in a primary energy failure. This happens in minutes. So there'll be sodium overload, there'll be excitotoxicity of the neurons. This happens immediately. Kan? Sometimes there may be tissue necrosis, there may be cell death immediate. And then bila dah jadi macam ni, the next step is reperfusion. So bila ada reperfusion, what happens is there'll be transient recovery of the cerebral metabolism. What happens? Dia akan naik. The calcium level will increase. Kan? Calcium level will increase. Kenapa jadi sodium overload ni? Because initial insult tu dia akan affect pada your sodium and potassium pumps. Sodium and potassium pumps will be affected, leading to depolarization of the neuronal membrane. Lepas tu your neurons akan start to excrete macam-macam. Dia akan excrete benda macam so sodium tak boleh nak move freely across the sodium and potassium pump. Lepas tu depolarization of your neurons pun will happen. So bila your neurons depolarize, what happens is dia akan release excitatory neurotransmitter. Contohnya macam apa? Macam glutamate. So glutamate ni akan di excreted into the synaptic cleft. So this is what causes the neurons to be excitotoxicity. So it becomes so baby akan jadi macam tu hyper alert. Lahir at birth pun you akan nampak dia dah mata terbeliak, dia akan irritable. So this is what happens. And then cerebral metabolism transiently recovers. So masa ni apa jadi ni is overactivation of the glutamate apa semua ni result in calcium overload. So calcium akan keluar. Lepas tu apa lagi? Lepas tu this is ROS ni there's function of the free radicals. Apa free radicals? Contohnya nitric oxide. Contohnya macam ROS. ROS ni is reactive oxygen species. Reactive oxygen species ni contohnya apa? Contohnya macam superoxidase, contohnya macam peroxidase, contohnya macam oksigen singlet oksigen yang zero -1 tu. So these are all oxygen free radicals. So semua ni can cause lots of damage to the tissue. Okay, so this happens within the first 6 hours. This first one, the primary energy failure occurs in minutes, and then transient recovery ni occurs within hours. So the next step, secondary phase, this happens after 6 hours. So after 6 hours, these are the delayed phase. These are the delayed action. So apa jadi? After 6 hours, now come the secondary phase. What happens is there will be mitochondrial dysfunction. The mitochondria will not be functioning properly. Tissue metabolism will be affected, caspase activation, and result is delayed result in apoptosis and cell death. So bila kita nak start treatment, kita kena start before 6 hours. The treatment should be initiated before 6 hours. Sebab kalau kita start after 6 hours, the secondary phase has already set in. The mitochondrial dysfunction has already set in. So kita nak buat treatment, it should be before 6 hours. So apa treatment dia? Among the treatment is hypothermia lah. So we'll talk about hypothermia in a bit. So macam mana tadi as I mentioned before, firstly there'll be cellular injury and death. At the initial phase ni sebab apa? Sebab failure of ATP dependent pumps, your sodium and potassium pumps, and then excitatory amino acid macam glutamate, release of glutamate, so it become excitotoxic, influx of sodium and calcium into the cell, so results in edema and causing the cells to be damaged. And in delayed secondary phase, ada apoptosis and tissue injury. Okay, what are the cause and risk factors? There's a lot of causes and risk factors. Maybe they are maternal, placental, fetal, intrapartum causes. Maternal contohnya macam apa? Contohnya macam low socioeconomic status, family history of seizures, all this can result in hypoxic and ischemic insult. Maternal thyroid disease is among the known cause of hypoxic events. Preeclampsia, post-date, abnormal placentas. IUGR is a known cause of hypoxic ischemic babies as well, and others. Okay, we're not going to go there as I've mentioned before. So there's a lot of things. Umbilical cord punya problem, such as knotting cord presentation. So how do we diagnose hypoxic ischemic encephalopathy? So the diagnosis, this is the criteria. So how do we diagnose HIE? Dia ada tiga criteria. The first one is early onset of moderate or severe encephalopathy in a newborn. More than 35 weeks, as I mentioned before, kalau premature kita tak boleh label dia as hypoxic ischemic encephalopathy because of the different physiology in more premature babies. So ideally kita should assess dengan AEG, CFM. Susmed when I left, kita baru nak beli, bajet dah dapat daripada Jabatan Agama. So I'm not sure we have bought or not AEG. So we should have. So AEG ni kita boleh nampak dia punya cerebral function. So the first criteria is early onset. moderate or severe encephalopathy, nombor 1. Nombor 2, dia ada neonatal signs consistent with intrapartum or peripartum event. Contohnya apa? Contohnya arterial cord pH yang less than 7.0, Apgar score of less than 5 at 5 minutes and 10 Apgar score of less than 5 at 5 and 10 minutes, 5 or 10, and evidence of multi-organ system dysfunction within 72 hours after birth. Maknanya if you do cardiac enzyme, for example, you see elevated CK. If you do liver function, you see deranged transaminases. If you do renal profile, you see deranged urea, creatinine, and so on and so forth. So there are signs suggestive of multi-organ system dysfunction because of the hypoxic and ischemic insult. If you do neuroimaging, you will see signs, evidence of acute brain injury. Tapi benda-benda ni mesti ada, they should be consistent with intrapartum punya timing. Maknanya dia mesti within intrapartum punya period. Mesti ada sentinel hypoxic or ischemic event occurring immediately before or during delivery. So fetal heart rate pattern pun suggest abnormal during labor or after that event. And the third criteria is absence of infectious cause, congenital malformation of the brain or an inborn error of metabolism, or other conditions which could explain the encephalopathy. So maknanya kalau kita nak label as hypoxic ischemic encephalopathy, it must be a perinatal event and it must be explainable only by hypoxic ischemic insult. Tak boleh ada event lain, tak boleh ada cause lain yang boleh resultkan macam ni. It's very important because it may be medico-legal. So how do they present? So the initial physiologic response, so the first one is redistribution. So redistribution ni pun boleh cause banyak problem lah, boleh cause banyak problem. So if you look at hypoxic ischemic event, dia akan involve organ. So presentation pun will depend on which organ that is affected. The first one, as mentioned before, should be the brain lah. Sebab tu dia encephalopathy. So masa at birth, apa kita nampak? The baby will often have low Apgar score. Low Apgar score, dia ada weak or absent cry. Breathing, dia may be affected. There may be poor muscle tone. So show signs of impact neurological function. So they may have abnormal state of consciousness. Mild punya dia akan jadi hyper alert, buka mata besar, macam irritable sikit kan, and then lethargic, or moderate dia akan jadi lethargic, and severe dia akan jadi obtunded, comatose. So there may be diminished spontaneous movement, baby tu tak gerak, flat kan, respiratory suppression and feeding difficulty, dia tak boleh suck, tak boleh swallow, poor muscle tone, abnormal posture, decerebrate, decorticate posture. And primitive reflexes pun akan absent. Apa contoh primitive reflexes? Morose reflex, sucking reflex, palmar grasp, plantar grasp. Semua-semua ni nanti kita akan assess. And assessment of encephalopathy ni kita akan guna dua, sama ada Sarnat or Thomson score. Sarnat and Sarnat dengan Thomson scoring. I'll show you after this. So this is modified Sarnat classification or Sarnat and Sarnat classification. So modified Sarnat classification ni kita classify HIE itu into 3. Mild, moderate, severe, or stage 1, stage 2, stage 3. So apa elemen yang kita tengok? First, level of consciousness. Kalau mild, as I mentioned before, dia akan hyper alert. Mata tu boleh lahir-lahir mata besar kan. Tengok macam hyper alert lah, hyper alert. Kalau moderate dia lethargic, severe dia akan comatose. Muscle tone dia mild, normal. Moderate dia akan hypotonic, and severe dia akan flaccid, akan flat. And primitive reflexes mild, biasa, normal ataupun poor. Morose reflex akan exaggerated sebab dia hyper alert. This is because of the excitotoxicity. Kan? Kemudian kalau moderate, sucking reflex will be weak or absent, and morose will be weak or incomplete morose. Severe, all the reflexes will be absent. Seizures will not be present in mild. It can be present in moderate, and in severe HIE, it is very frequent and difficult to control. Okay. Prognosis wise, in mild HIE, usually is very good. Baby should recover well within quite early. Moderate usually can be abnormal, can be guarded prognosis, and if we do not treat properly within the first 6 hours, can lead to cerebral palsy. Severe HIE usually should have some neurological sequelae, and it can be severe, and it can lead to even death and severe handicap. So, yang ni how we classify HIE. Kita juga classify HIE using Thomson encephalopathy scoring. So, kita sanad classification ni is important untuk kita classify the severity. It's important for prognostication. Sanad classification. Thomson classification pula is important untuk treatment. Maknanya bila kita nak initiate treatment, bila kita nak start treatment dengan cooling therapy tu, depends on your Thomson encephalopathy score. And masa kita continue treatment pun kita assess masa treatment tu using the Thomson encephalopathy score. So sanad useful untuk initial and useful untuk prognostication. Thomson useful untuk treatment and management. Initiation of treatment and throughout monitoring masa on treatment. And treatment is cooling lah. We'll discuss about this later. So kita akan start cooling therapy as soon as the score is more than 7 in the first 6 hours of life. And then bila kita dah start, kita kena monitor frequent. Okay, apa kita tengok? Kita tengok pada tone, conscious level, seizures, posture, morose reflex, grasp reflex, sucking reflex, respiration and fontanelle of the baby, and 0, 1, 2 and 3. So kalau dia reach 7 je, kita should start cooling therapy, and ideally should start within the first 6 hours of life. Okay, that's the neurological. Next is respiratory system. So respiratory is affected in 71 to 86% of the patient. It's frequently seen. Usually it can be, usually there may be underlying problem yang lain juga lah, sepsis, pneumonia, meconic aspiration. And perinatal asphyxia is associated with PPHN. So among the causes of PPHN is perinatal asphyxia. So when you have a child with perinatal asphyxia, we should always watch out for PPHN. So infant with respiratory failure may require intubation and mechanical ventilation. So mechanical ventilation pun ada banyak complication dia kan. So infants who are treated with hypothermia, cooling therapy, typically they are intubated and mechanically ventilated. Sebab kita coolkan dia, everything will be slow and so on and so forth. Next is cardiovascular, which accounts for 43 to 78%. Hypoxic ischemic insult may result to reduce cardiac output, and cardiac function akan jadi impact cardiac function because impact myocardial contractility due to ischemia and so on and so forth. So we can the baby may have hypotension, and if you do echo, we'll see ventricular dysfunction and poor cardiac contractility. So kalau kita buat ECG, kita akan boleh nampak ST depression and T wave inversion. Kalau kita buat cardiac enzyme, kita akan nampak elevated CK, elevated LDH and troponin. But usually kita do CK sajalah. Kidney function affects 46 to 72%. So semua baby akan ada oliguria, but it will be more pronounced in babies with hypoxic ischemic encephalopathy. Why? It can be due to reduced cardiac output. Bila reduce cardiac output, reduce renal perfusion. Tapi ia juga is caused by secondary kidney injury due to tubular necrosis. So it can be because of it can be pre-renal, it can also be renal itself because of the hypoxic event. Liver accounts for 80 to 86%. You may see deranged transaminases, elevated ALTs, elevated ASTs, and so on and so forth. GI. So there may be feeding intolerance in babies, because especially GI ni is among the organs yang our body kan, bila we don't have enough, when there's hypoxia, when there's hypoxemia, the body will redistribute blood flow from the splanchnic GI circulation to other vital organs macam brain. So GI ni our body probably it thinks it's among the least important organs. So it's among the first yang affected. So bila ada impact GI perfusion, there can be feeding intolerance. Feeding intolerance. It may even result to necrotizing enterocolitis. Hematological system is affected in 32 to 54%. There may be impact coagulation. There may be thrombocytopenia. Why? There's a lot of reason why. It can be because of consumptive coagulopathy, consumptive thrombocytopenia. It can be because of bone marrow suppression, because of the hypoxic event, also because of liver derangement. And so there'll be impact production of your coagulation factors, and also there can be result in because of the hypoxemia and acidosis as well. There may be increase in bleeding time and endothelial dysfunction. So also it affects your glucose metabolism. It affects your glucose metabolism because obviously glucose metabolism needs oxygen and so on and so forth. So how do we manage? So principle of management, the first thing is always clinical stabilization. We need to stabilize the patient, stabilize the baby clinically. Assess the extent of end organ injury, whether there's any, which organs are involved, and if we can identify treatable condition, then we need to treat all those treatable conditions. And if there's any concomitant or condition, that needs to be treated as well. Make sure we have adequate ventilation if the baby needs ventilation, because sometimes bila kita bagi cooling therapy ni, dia akan suppress kan, dia akan suppress breathing apa semua. So sometimes we may need to give ventilation support. So we need to make sure there's no hypoxia, but there should be no hyper or hypocapnia as well. So carbon dioxide level should be maintained as well. Adequate tissue perfusion, make sure the BP is optimized. Many of the times in babies with hypoxic ischemic encephalopathy, we may need inotropic support. Especially if the baby then needs cooling therapy. If there's seizure, we need to control the seizure. Dengan apa? Usually the first line of anti-epileptic medication is still phenobarbital. We should not use phenytoin, we still use phenobarbital. But since last year, there have been a problem with supply of phenobarbital. So now the second line, which many centers are now using as first line is, apa nama tu? Allah, can't remember. So we need to control the seizure. Fluid correction. Make sure that there's no fluid overload and not so if there's blood loss, for example, so we need to correct the fluids. Make sure electrolytes are maintained well, as mentioned before. There's sodium overload, there's sodium, potassium issue, calcium. So all these things needs to be corrected. And most of the time, especially when kidneys is affected, we need to fluid restrict the patient. So for the first day of life, sometimes rather than starting on 60 ml per kilo per day, we start on 40 ml per kilo per day, for example. So that's renal impairment. Investigation, as usual, blood gas to look at acidosis, and then full blood count, blood sugar, renal profile, liver function test, CK, probably need echo, ECG, and so on and so forth. Okay, so let's go there. Ideally, we need to monitor with CFM. Okay, next, therapeutic cooling, hypothermia, therapeutic hypothermia. So normal temperature for newborn babies are 36.5 to 7.5 kan. So therapeutic cooling ni is for babies who have moderate to severe HIE. Again, looking at your Thompson score, if it reaches 7, then we should start therapeutic cooling. So kriteria dia HIE dia macam yang how we diagnose lah kan, pH of less than 7.0 or base deficit of more than 16 with moderate to severe encephalopathy. needing ongoing resuscitation effort, macam kena ventilate and so on and so forth. Ideally, therapeutic cooling should be done in center with neonatologists. If not available, should be transferred out. So kita tengok. So this is again from the pediatric protocol. If baby is more than 35 weeks, less than 6 hours, again 6 hours is where your delayed phase happens, your mitochondrial dysfunction, cache space activation. So we need to start this before the delayed phase. So more than 35 weeks, less than 6 hours, and probable intrapartum hypoxia. So there should be a sentinel event. Baby meets criteria, yes or no? Kalau no, then we continue to observe. Kan kalau yes, kita commence cooling. Kriteria ni kita look at the Thomson scoring kan. So commence cooling as soon as possible within the first 6 hours of life if no contraindication. Contraindication macam apa? Contohnya very large subaponeurotic hemorrhage. Sebab we look at among the complications So kalau tak ada contraindication, then we should begin. So ideally rectal temperature bila kita coolingkan baby tu, ideal rectal the target rectal temperature is 33 to 34 degrees Celsius. Kalau axillary kita aim 33.5 to 34.5. Sama ada macam mana? Sama ada kita buat cooling blanket kalau ada kan. Kita letak cap yang boleh coolkan. Dia ada ice atau dia macam tu. Ataupun kita buat active or passive cooling. So passive cooling ni it just means kita coolkan the baby passively. Kita offkan radiant warmer, kita make sure aircon is on. Then kita try to coolkan the baby. But it's not as effective lah. And the temperature will fluctuate. Active cooling ni ada mesin dia. Alhamdulillah in Susmac we have the cooling machine. So cooling machine ni dia akan kita cover the whole body, ada sampai kat kepala, and it will reduce the baby's body temperature, and dia ada rectal punya thermometer pun untuk maintain the temperature of the baby at 33 to 34 degrees Celsius. So kita nak maintain this temperature ni for 72 hours from the beginning yang kita start tu for 72 hours. And then after the 72 hours finish, kita akan rewarm the baby over 12 hours by 0.2 to 0.5 degrees Celsius per hour. That's the maximum. Okay, faham tak? Okay, so what rewarming again as mentioned before, slowly over 12 hours. Increment by maximum is 0.5 degrees Celsius every 2 hours. What are the complications of therapeutic cooling? Sinus bradycardia. So baby akan jadi bradycardic. Macam kita cryotherapy kan. Dia kan memang bila low temperature your heart rate pun akan drop. So but usually it's transient and it's reversible. Blood pressure will be low as well. Dahlah dia hypoxic ischemic encephalopathy tu BP pun low. Bila you start therapeutic cooling, BP akan drop further. So the moment you start therapeutic cooling, most of the time you will need to prepare inotropes for the patient. They may be increase in oxygen requirement. All these are changes that we can see when there's cooling involved. So sometimes kita kena naikkan sikit FiO2. Kita kena naikkan sikit dia punya ventilation setting. Associated with thrombocytopenia as well, increased bleeding tendency. Sebab tu kalau ada massive SAH, massive subaponeurotic hemorrhage, sometimes that is a contraindication for therapeutic cooling as well. And then prolonged, you need to remember as well, with cooling, there will be prolonged drug half-life. So morphine pun sama. Morphine akan, the effect will be more because the half-life is longer. Phenobarbital, so there's a lot of medication, especially those that are metabolized in the liver. Sometimes it may be prolonged. The half-life will be prolonged. And if you rewarm the baby too fast, it may cause peripheral vasodilation and hypotension, and can cause a shock and can cause cardiac failure as well. So we need to we need to rewarm slowly over 12 hours. Prognosis directly proportionate to severity of the HIE, as mentioned before kan. Kalau mild, usually prognosis is excellent. But if moderate, it's guarded, and severe, it will be a very severe prognosis. So, yeah, that's it. Simple. Okay. How? Okay, understand? Clear tak? Clear tak so far?
Doctor, I
Yeah.
have a question.
Dapat tak?
What is the principle of the therapeutic cooling in HIE patient? I don't
So
really.
basically what it does is, again, if you remember, macam mana saya nak stop sharing ni? I don't have the button for, this is only resume share. Stop sharing tak ada. So basically what happens when you cool, okay, if you look at the, mana ni? If you remember, so this is the problem. The problem is hypoxic insult, energy failure because there's no oxygen, ATP will be problem as well. So it's going to go into apa nama tu, anaerobic punya metabolism. So your sodium potassium pump and so on and so forth. And the problem later is the apa nama tu, reperfusion. So reperfusion injury. So bila kita buat cooling, few things akan happen. Yang pertamanya, dia akan reducekan reperfusion. Dia akan reduce reperfusion. Dia akan reducekan reperfusion, dia akan reducekan effect of reperfusion. Number 3, dia slowkan metabolism. Dia slowkan metabolism. So everything, the processes tu, all the mitochondrial function, everything is dislowkan. So bila dia slowkan, so some authors kan, dia bagi tahu, dia suggest when you do therapeutic cooling ni, dia bukan actually prevent all the thing to happen, but it just makes the process to happen slowly. So bila process to happen slowly, the damage is not as bad. So that's among the postulation. So again, what happens is, satu, dia reducekan reperfusion injury. Nombor 2, it makes the metabolism and the damages slower. Okay, faham? Clear? Dapat tak? Faham? Ke confused? Pening? Khas sudah?
Boleh faham insyaAllah.
Boleh faham. Okay, larat tak? Satu lagi topik. Larat?
Boleh lagi.
Larat.
Boleh lagi.
Boleh.
Masih bernyawa lagi Masih surviving. Okay, let's this one insyaAllah I'm hoping it's not gonna be too long. Let me open my slide. Okay. Alright, screen share. Motion on the screen. I should just wait. Let me. Sorry. I should just do this. Sorry, let me open my slides first. Okay. Zoom, screen share. Okay. The next topic, I'm going to talk about prematurity and its complication. So prematurity and its complication. So what is premature babies? So premature babies are babies who are delivered before 37 completed weeks from the first day of the LMP. So those yang born after 37 weeks and above, they are considered as term. Tapi kalau baby yang born before completed 37 weeks, they are considered as premature. So prematurity is associated with more mortality and morbidity as compared to full-term babies. The lower the gestational age, the more complications that can arise. So some important definitions. So again, as I mentioned before, premature infants are infants born before 37 completed weeks. Maknanya until 36 plus 6 is considered as premature. 37 weeks and onwards are considered as term infants. Late preterm infants are those born 34-36 weeks. Moderately preterm infants are 32 and 30, between 32 and 36 weeks. Very preterm are more than born before 32 weeks period of gestation. Extreme preterm are those born before 28 weeks period of gestation. Next is we can classify according to satu tadi gestation. Now kita define dia according to dia punya weight. So low birth weight are those born less than 2.5 kilos. VLBWs are those less than 1.5 kilos. ELBWs are those born less than 1 kilo at birth. So and then kalau kita tengok kan, this is the average lah. This is the average. Those babies who are born by 24 weeks usually weight they around 600 gram or less. 25 weeks is 750 grams. 26 weeks 850 grams and so on and so forth. In Malaysia, in Malaysia and the whole world lah, when you have premature delivery, tak semua yang kita akan resuscitate, because all the complications yang I'll be talking about nanti, tak semua premature babies kita akan resuscitate. In some hospital in Malaysia, the cut-off point is 27 weeks and above. So only those babies who are born more than 27-week period of gestation sahaja yang dia akan resuscitate. Contohnya hospital Kota Baru HRPZ 2 dia ambil 27-week period of gestation and more than 500 grams. Kalau baby tu more than 500 grams and more than 27-week period of gestation, baru akan resuscitate. Most hospital in Malaysia, even HTA, even SASMEC, kita ambil 25-week period of gestation and 500 gram and above. Maknanya kalau baby tu born less than 500 gram, kita tak resuscitate. Kita bagi to mother, allow tender and loving care, palliative care, baby will die. Kalau baby itu born less than 25 weeks, kita tak resuscitate. Okay, so generally 25 weeks and above in Malaysia kita resuscitate. 24 to 25 weeks dia akan depend pada discussion. So any risk factor kita akan counsel dengan parents dulu. 24 to 25 week ni is by discussion and looking at the condition of the baby at birth. Kalau baby tu tunjuk signs of life, kita akan resuscitate. Tu pun ada ceiling dia. But 25 weeks and above kita resuscitate. 24 to 25 kita tengok condition at birth and by discussion and consultation. Less than 24 weeks in Malaysia kita memang tak resuscitate. Kita akan buat palliative care with mother, tak masuk NICU pun. Kalau in many countries macam many developed countries, UK, US, dia ambil 24 weeks. And any baby who's born more than 24 weeks, dia akan resuscitate. 23 to 24, dia tengok condition baby at birth. 22 to 23, more severe. Only in certain specialized hospitals saja. If you go to more developed countries, macam Canada, macam Japan, they are taking now 22 weeks. Babies born more than 22 weeks, they resuscitate. So Malaysia kita still far lah, We don't have enough neonatologists, we don't have enough neonatal ICU beds and so on and so forth. So it's still a long way to go for Malaysia. So in the US, those VLBWs accounts to 0.7% of live births. 99% of them are premature. And prematurity is associated with lots of things. Some of them are associated with low birth weight, and majority of low birth weights are premature, and they have correlation with birth defects, and there are subsets of babies who have both low birth weight, birth defects, and also prematurity. One thing I need to always mention, prematurity is associated with a lot of economic consequences. In the US alone, US ni dia punya healthcare system dia pelik lah, is insurance based, so it's very costly. In the US, it's very costly. Kalau in UK, everything is free. UK, everything is free. Tapi walaupun free, there's someone who's paying. Siapa yang bayar is the government who's paying. For example, one NICU bed per night in the UK, government kena bayar pada hospital. Sebab in UK, for example, hospital dia tak ada hospital government. Dia tak ada hospital dia. Every hospital is a trust, yayasan sendiri, is a trust. Hospital semua is a trust. Dan trust ni, dia ada trust yang run NHS punya patient. So government punya patient. So government yang akan bayar pada patient tu. Ataupun ada juga private punya patient. Okay. But generally, kalau NHS yang bayar, dia charge dia sama je. So kalau NHS yang bayar, government yang bayar, for each patient, government kena bayar kalau masuk NICU, minimum is 1,400 British pound per day. Kalau HDU, bayaran dia is around 800 to 1,000 British pound per day. Kalau SCN is around 300 to 500 British pound per day. Kalau transition care is around 150 British pound per day. So can you imagine, we have babies who are admitted in NICU for months. When I was in USM, we've had babies yang admitted kat situ for 1 year and 4 months. Daripada lahir, discharge NICU at 1 year and 4 months. I think when I was in Susmek, our longest was 11 months, 10 months plus, almost 11 months. So baby daripada born, discharge to at almost 11 months. Can you imagine how much is the cost? We've had babies before who's admitted to NICU Susmek under private wing for 2 months plus. The total charges is almost 150,000 ringgit. So the charges tu is exorbitant. Sebab cost of ventilation, oxygen, machine, all the procedures, all the bloods and so on. So the charges are very, very high. Very, very high. So it's a lot of cost, and long-term cost pun banyak. There's a lot of community health services, educational services. Many of them, especially kalau ada cerebral palsy and so on and so forth, may need special education. Lots of learning issues. Autism, for example, among the causes for autism is prematurity, and lots of out-of-pocket expenses. We've had patients before born in Susmek, premature, born at 32 weeks period of gestation. Is a twin. Mother is not working. Father is a undertaker, penggali kubur. Duduk dekat Maran. Hospital lain tak boleh cover sebab tak ada NICU backup. Susmek was the only hospital that has NICU at the time. So delivered in Susmek. Father dia is an undertaker. Gaji income sebulan not even 1,000 ringgit per month. They don't have a car. Datang follow up bawa motor. Datang follow up bawa premature baby ni naik motor. Can you imagine? Mak dokong 2 baby for follow up. So it's a huge punya expenses. We've had babies before. Parent orang susah. Datang kena naik Grab. Pinjam duit. Setiap kali nak datang follow up, pinjam duit jiran. Setiap kali nak datang follow up, pinjam duit jiran. So it's a huge cost for everyone that is involved. So there's a lot of issues juga yang causes premature delivery, genetic, environmental, and so on and so forth. So prematurity is the number 1 cause of neonatal mortality in the United States, and is the second cause of infant mortality in the US. So the more premature the baby, the more problems. The more it is associated with morbidity and mortality. You see here, 38 weeks, less problem with respiratory problem, sepsis, IVH, NEC. The more premature the baby, the more it is, the more problems it is. Okay, next. What are the causes for premature deliveries? Preeclampsia, fetal distress, IUGR, abruption placenta, or fetal demise. Okay, let's go a bit faster. Known risk factor for premature birth. System for mother yang inflammatory problem or over distension of the uterus such as in multiple pregnancy, polyhydramnios, uterine abnormalities, cervical abnormalities, and so forth. Okay, we'll not go there. Okay, what are the problems with babies? So in newborn babies, we've discussed before how they need to adapt from intrauterine life to extrauterine life. So the problem with premature babies are all the systems are not ready yet for the external environment. All the systems, all the organs, all the tissues are not ready yet. The lungs are not formed yet. For example, alveolar, the proper alveolar are formed at around 25, 26 week period of gestation. So kalau baby is born at 24 weeks, alveolar tu tak ada pun lagi. Dia only ada terminal bronchioles saja. So the gaseous exchange are done at the terminal bronchioles. Kan? Surfactant are produced by 24 weeks. Before 24 weeks, surfactant, there's no surfactant. Kan? Kita kena supplement with surfactant. And then apa lagi? Immune system. So maternal antibodies. Maternal antibodies apa yang boleh cross placenta? Maternal IgG, maternal IgM does not cross placenta. Maternal IgA boleh cross placenta tak? Siapa boleh jawab? Maternal IgA boleh cross placenta? Ada? Boleh ke tak boleh?
Boleh tu.
Ha?
Tak boleh.
Kenapa tak boleh?
Mula kira besar.
Sebab IgA is secretory. So IgA dekat breast milk. So IgM dia tak cross placenta sebab IgM is a big molecule. IgG is a smaller molecule, so IgG akan cross placenta masuk dekat baby. Some IgM crosses placenta. For example, dengue IgM boleh cross placenta. Varicella IgM boleh cross placenta, but majority of IgM does not cross placenta. Maternal IgG boleh cross placenta. Sebab itu yang jadi rhesus incompatibility, itu yang jadi ABO incompatibility kan. Contohnya mak darah O, baby darah selain daripada O, baby darah B, baby darah A kan. Mother darah O, mother tak ada antigen A, tak ada antigen B, mother ada antibody against A, ada antibody against B. So this antibody are the ones that crosses from mother into baby and causes hemolysis. Yang tu yang jadi ABO incompatibility. Sama juga dengan NATS, Neonatal Autoimmune Thrombocytopenia. So apa jadi is baby ada platelet pada baby tu is dia express yang paternal punya antigen. Kan? Platelet baby dia express paternal, father punya antigen. So mother pula dah expose, so mother produce antibody. So this antibody against paternal platelet antigen cross placenta masuk dekat baby and causes thrombocytopenia. Ini kita panggil neonatal autoimmune thrombocytopenia, NAT. So IgG crosses placenta. The problem is IgG crosses placenta at around 18 to 20 weeks. So kalau the earlier the baby is being born, not much IgG. Bila not much IgG, the baby are more prone for infection and so on and so forth. So there's neonatal complication such as RDS. So RDS is hyaline membrane disease. It's because of lack of surfactant, surfactant deficiency. So bila lack of surfactant, alveolar dia boleh collapse, airway dia boleh collapse. Bila airway dia collapse, can cause respiratory distress syndrome. Lung compliance is impaired. Baby needs surfactant, needs ventilation and so on and so forth. There may be the brain is immature. Bila the brain is immature, dia senang, the vessels fragile fiber, dia senang bleeding, especially at the periventricular region. Sebab itu dia boleh dapat intraventricular hemorrhage. Dia ada 4 stages, four stages of IVH. Stage 1 IVH is periventricular hemorrhage. Periventricular hemorrhage. Stage 2, dia ada intraventricular hemorrhage without dilatation of the ventricles. Stage 3 is when there's intraventricular hemorrhage with dilatation of the ventricles. And stage 4 is when you have intraparenchymal hemorrhage. So ni IVH. So stage 1 stage 2 IVH, prognosis is good. Stage 3, stage 4 biasanya poor prognosis. Kan? And then because the bowel are immature, the vessels lining the bowels are immature, they are more prone, and dia tak ada the normal gut flora. Bila tak ada normal gut flora, yang more pathologic punya organisms senang nak grow, Klebsiella, Acinetobacter. So, and this can result in necrotizing enterocolitis. The muscles, kita, if you remember sebelum ni kan, bila baby deliver kan, baby starts to cry, increase in FiO2, oxygen level, so dia akan causes contraction of the smooth muscle dekat ductus arteriosus. The problem is in premature babies, the smooth muscles lining the ductus arteriosus are immature. Bila the lining the immature, dia tak boleh nak close properly. They are prone for infection. Dia punya skin dia, if you remember, the skin ni, our skin is innate punya protective mechanism kan. Kita punya skin ni is innate, kita punya protection. So anything yang break the skin akan cause infection. Premature baby, the skin are very fragile. Bila skin ni very fragile, very thin, infection pun senang set in. Premature babies, they are admitted in NICU. Longer you stay in NICU, the more at risk you are to get infection. Premature babies, kita set line. Each time kita set line tu, kita exposing the patient to infection. Kita intubate sebab RDS, risk of ventilator associated punya infection and so on so forth. Kan? Kita letak indwelling catheter yang lama. Kan? Kita letak PICC for example. All these are risk of infection. They are more prone to get metabolic abnormalities, nutritional deficiencies, and so on so forth. So head to toe, daripada kepala, brain dia, nanti kita go satu-satu lah. So daripada brain dia, IVH, PVL, kan, mata, they may get retinopathy of prematurity because the vessels lining the retina tu are immature, and sometimes bila ada fluctuation of oxygen, contohnya kita bagi high oxygen, kita bagi high FiO2, kita ventilate the baby, kita bagi high oxygen, so high oxygen, and then kita reducekan fluctuation of oxygen tu. Oxygen, dua problem dia. Satunya, oxygen has free radical, reactive oxygen species. So this ROS ni is boleh damagekan dia punya retina tu and causing retinopathy of prematurity. Nombor dua, kita ventilate dengan high oxygen and then kita reducekan. So there are episodes of hypoxia to the retinal tissue. These are the two factors that results in retinopathy of prematurity. So baby may go blind kalau kita bagi too much oxygen in premature baby. Sebab dia punya tissue dia, retina dia very fragile as compared to more term babies. So mata dia boleh dapat retinopathy of prematurity. Mulut dia, sucking. Kita ingat sucking ni is easy. Tapi in premature babies, sucking is difficult. Sucking reflex appears only around 35 weeks period of gestation. Sucking reflex appears around 35 week period of gestation. So before 35 weeks, babies usually dia tak pandai pun nak suck macam mana. Kan sucking is a reflex. Kita masuk benda, dia akan suck. Tapi in premature babies less than 35 weeks, dia tak pandai nak suck. Swallowing pun sama. Swallowing appears around 34 week period of gestation. Kadang-kadang dia boleh suck, dia boleh swallow, tapi ada sucking swallowing discoordination. Sebab bila kita suck, kita punya swallowing punya dia kena coordinatekan. Ada masa nak kena tutup, nak kena buka epiglottis. So in some premature babies, dia ada sucking swallowing discoordination. So problem, feeding intolerance. Kan? Dia punya lungs dia immature. So dapat RDS, hyaline membrane disease sebab tak ada surfactant. Sebab alveolar pun tak form lagi. So on so forth. Cardiac dia boleh dapat PDA. Kan, heart dia boleh dapat PDA. Lepas tu GI dia, risk senang nak dapat apa? Senang nak dapat NEC, feeding intolerance. Immune system dia as mentioned before, hematological. Dia boleh dapat anemia of prematurity. Sebab apa anemia of prematurity? Satu, sebab bone marrow dia still immature, so tak boleh nak produce much hemoglobin. Lepas tu pula dia dalam admit ward, kita ambil darah, so iatrogenic, kan, iatrogenic causing anemia and so on so forth. Coagulopathy and so on so forth. So it's a head to toe punya problem. And long term, they may have cerebral palsy, sensory deficit, school autism is a known cause, is a known association dengan prematurity and so on so forth. Okay, let's look at one by one. So if you look at how they present, kan, dia punya, kalau term baby you nampak wrinkles dia, creases dia. Tapi kalau premature baby dia smooth saja, dia tak ada crease tu, kan. Apa nama breast nodule dia pun, breast bud dia, term baby ada breast bud. Premature baby sometimes flat, ada nampak dia punya nipple saja without the breast bud. Lepas tu weak or absent Moro's reflex, sucking reflex, grasping pun tak ada. Why? Because prematurity. So the more mature baby tu baru akan ada. So usually sucking reflex, as mentioned before, appears 35 weeks and above. Kan, testis may be undescended, scrotum dia pun not properly developed. So susah dia punya testis dia nak turun masuk and so on so forth. Okay, how do we assess? Yang ni I'm not sure. I hope ada lecture pasal newborn assessment tu. Neonatal assessment tu we should have talked about ballot scoring. So ballot scoring ni ideally should be done within the first 12 hours, but it can be done up to day 4 of life. So kita assess physical dia and kita assess dia neuromuscular punya maturity. So physical maturity ni, actually this is very interesting sebenarnya. So we talk about dia punya skin dia, the more premature the baby kan, ni 0, 1, 2, 3, 4, 5 macam tu, kita marking kan dia. So sticky, friable, gelatinous, smooth pink, visible vein ni more mature. Ni more ke sebelah kiri is more premature, sebelah kanan ni is more mature baby. So kita marking kan dia 0, 1, 2, 3, 4, 5 macam tu. So lanugo ni bulu-bulu dekat belakang, non sparse abundant bla bla bla. So plantar surface dia ada creases ke tak, breast dia macam mana, ears, genital, and then kita assess dia punya, and then kita buat scoring dia. So by this scoring kita boleh tahu sebenarnya baby ni is mature ke is premature, berapa dia punya gestation dia yang actually. And then kita look at dia punya neuromuscular, posture dia macam mana. Ni scoring ni tadi macam ni. Negative 1, 0, 1, 2, 3, 4, 5. Negative 1. So negative 1, 0, 1, 2, 3, 4, 5. Kita campurkan yang sini semua, campurkan dengan yang neuromuscular punya maturity ni, kan? Dan kita scorekan. So contohnya posture dia macam mana? 0 macam ni, 1 macam ni. Square window ni square window tangan dia. Dekat dia punya wrist dia. Kan, the more premature the baby, the more dia tak boleh nak flexkan dia punya wrist. The more term baby, dia boleh flexkan lagi banyak. Dia boleh flexkan dia punya wrist. Arm recoil, operated angle. Campur yang neuromuscular maturity ni, campurkan dengan yang ni. Berapa marking dia. So kita dapat, contohnya kalau dapat marking 30, is actually around 36. Tapi biasa kita akan dapatkan range. Kalau 20 to 25, so dia punya gestation age dia is 32 to 34 weeks gestation. Okay, next is respiratory. So kita dapat biasanya, so in more premature baby, as mentioned before, they are at risk of respiratory distress syndrome, hyaline membrane disease. They are more risk of pneumothorax. Sebab apa? Sebab dia punya they may need more ventilation, and ventilation can cause barotrauma and also pneumothorax. The higher the pressure yang you ventilate the baby, you are exposing the baby to barotrauma, so pressure, trauma to the lung tissue because of high pressure. You bagi PEEP, positive and expected pressure tu tinggi sangat, and you can cause barotrauma. Kalau you kena back tinggi sangat, sometimes you can cause sampai pneumothorax and so forth. They are more risk to getting congenital pneumonia and apnea. So apnea ni apa? Apnea of prematurity. Kenapa dia apnea of prematurity? Because brain dia immature. Brain dia yang triggerkan breathing ni kat mana? Triggerkan breathing ni is in your pons, your cardiorespiratory center dekat pons. So untuk normal breathing effort tu, dia kena your pons must be mature enough. Bukan setakat pons must be mature enough. The receptors tu must be mature. Receptor tu dekat mana? At your carotid body, your aortic body. So nak triggerkan cardiorespiratory center tu, your carotid body and aortic body tu must be mature enough. Your cardiovascular, as mentioned before, PDA can have hypotension because of immature myocardium and so on and so forth. And with apnea, you can have bradycardia as well because of suppression in your cardiorespiratory center. Anemia, as mentioned before, you can have anemia of prematurity because of immature bone marrow or immature liver, kan? Your fetal hemoglobin is produced in your liver, kan? And it can also be iatrogenic. For example apa? You ambil darah selalu, kan? Newborn baby kita ambil darah. If you remember, kan, kalau you ambil full blood count. So full blood count you need berapa? You need 0.5 mils. 0.5 mils of blood untuk hantar full blood count. Kalau you nak hantar renal profile, liver function test, you need around 1 mil. You nak test untuk coagulation, PT, APT, INR, you need around 1.5 mils of blood. Lepas tu you nak test thyroid function, you need around 2 mils of blood untuk thyroid function. You nak test untuk inborn errors of metabolism, you need up to 10 mils of blood. If you can imagine, for example, a 1 kilo baby, total blood volume is only around 80 mils per kilo. Total blood volume in a human being, in a baby, is 80 mils per kilo, 80 ml per kilo. Kan? So kalau kita dah ambil darah, for example, sekali ambil darah, ambil blood gas, you need 1 mil, for example, kan? Blood gas 1 mil. You ambil FBC, bla 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 semua, you ambil 5 mils. Kan? Kalau satu hari you ambil blood mungkin 2 kali, that's only 10 mils. Kan? And the total blood volume in a 1 kilo baby is only 80 ml. So there's a lot of bloods. Bila you ambil blood banyak, then you can cause iatrogenic punya anemia. And the liver are immature. Bila liver dia immature, there's not enough iron storage. Di lahir awal, liver pun immature, storage of iron pun tak banyak lagi, so you can get iron deficiency anemia. So sebab itu premature babies most of the time kita kena supplementkan dengan vitamin D, kita kena supplementkan dengan iron. Kita kena bagi iron supplement. And they are at risk of disseminated of the IVC, for example. They may have vitamin K deficiency because breast milk does not have vitamin K. Sebab tu kita kena bagi vitamin K. GI, as mentioned before, the GI, they may have poor GI function. Dia punya smooth muscles are more immature. Bila smooth muscles are more immature, you remember kita punya gut ni, kita punya stomach ni dia ada dua sphincter, kan? Cardiac sphincter dengan pyloric sphincter. Kalau cardiac sphincter dia immature, what happens? Dia senang dapat reflux. So they are more prone to get gastroesophageal reflux disease. Many premature babies, we need to start on anti-reflux medication, for example. They are more prone to get feeding intolerance because dia punya peristalsis tu not moving really well. So dia senang dapat feeding intolerance. They are at more risk to get necrotizing enterocolitis, as mentioned before. So dia tak ada normal gut flora tu. And then the gut tissue tu are very immature. So microorganism senang masuk, kan? And they are more friable. So senang dapat NEC. And they are at more risk of hyperbilirubinemia. Sebab apa? Sebab the liver is immature. They are more prone to get metabolic and endocrine problems such as hypocalcemia, rickets of prematurity. Kita buat darah, liver function test, kita nampak apa? Kita nampak elevated alkaline phosphatase. That's among the signs of rickets of prematurity. Dia dapat hypoglycemia. Sebab apa? Sebab dia tak ada banyak, they don't have enough fat. They don't have enough glycogen storage. The glucose metabolism also is still immature, so dia tak boleh nak process properly, kan? and then they are admitted, dia tak dapat nak sucking and feeding properly, so they are at higher risk of getting hypoglycemia. They are at more risk of hyperglycemia juga. Sebab apa? Sebab satu stress, hyperglycemia. So hyperglycemia can cause stress. Lepas tu dia punya pancreas pun still immature. Bila pancreas dia still immature, dia tak produce insulin kan dengan properly. The insulin receptors pun immature. So they are at risk of developing hyperglycemia. They don't have enough brown fat. I mentioned before, masa previous lecture yang pasal adaptation to extra-uterine life, macam mana brown fat tu is very important untuk thermoregulation. Kan? So more premature babies, they don't have enough brown fat. When they don't have enough brown fat, they are more at risk of hypothermia. The smaller the baby, the larger the body surface area to weight ratio. Kan? BSA dia memanglah lagi kecil, tapi BSA to weight ratio is higher the more premature the baby. So they are at risk of more hypothermia. CNS, as mentioned before, IVH, they are more at risk of seizures. Kenapa? Sebab electrolyte punya problems, sebab dia punya brain is still immature, very fragile, very friable. IVH can cause seizures as well, retinopathy of prematurity as mentioned before, deafness, hypotonia and so on and so forth. Kidney problems, hyponatremia. Because why? Because kidney dia tak function really well. So sodium tu senang, it's more porous. Sodium akan keluar, so dapat hyponatremia. Can get hypernatremia as well because the kidney functions are still immature. Kidney functions are still immature. They are more at risk of renal tubular acidosis and so on and so forth. They are at risk of congenital infection as mentioned before sebab dia punya immune system dia are more immature, dia tak boleh nak fight infection really well. Perinatal infection pun dia lebih mudah because why? Because they are admitted, and they are admitted, they can get nosocomial infection and so on and so forth. For long-term complication, they are at more risk of recurrent hospitalization. The more premature the baby, usually the longer the hospitalization and more recurrent hospitalization as well. They are at more risk of developing BPD, chronic lung disease, retinopathy of prematurity, and they are the ones that are more at risk of having poor growth and feeding problem. Prematurity is among the known risk factor for cerebral palsy. Prematurity is among the known risk factor for learning problems. Prematurity is among the known risk factor for autism and so on and so forth. Because dia ada IVH. IVH tu kan ada blood. Kan kalau dia bleeding dalam ventricles. Bleeding ni ada blood to clot. Blood clot ni then boleh block dia punya aqueduct of Sylvian for example. So apa jadi? Dia boleh result in post-hemorrhagic hydrocephalus. They are more at risk of developing post-hemorrhagic hydrocephalus. So operation lagi and so on and so forth. So that's it. Prematurity and its complication. Clear? Ada soalan? Pening, tidur belaka. Nampak gambar ni Zulfarhan dia yang ada. Yang lain tak ada. Zulfarhan masih lagi dekat year 4 dia tulis tu. Padahal ada year 5. Ramai semua tulis year 4 dekat nama. Ada soalan? So, prematurity boleh masuk exam tak? Obviously MCQ everything under the sun boleh keluar lah. Kan? Everything under the sun boleh keluar. Can it come in KFQ? It's usually a bit difficult. Sebab kita akan tanya in the line yang contohnya macam cerebral palsy. So among the problem is prematurity. Kan? Boleh datang dalam clinical exam tak? Menowski ke? Boleh, in the sense yang bukan premature to itself. You won't get neonates for your clinical exam. But you can get apa? Complications of newborn problem. Contohnya cerebral palsy. So kita akan discuss lah. Now we expect you to know about prematurity ni. Ada discussion tak? So maybe among the, as mentioned before lah, among the causes of cerebral palsy is prematurity. So those are the line yang kita akan boleh masuk exam. Okay. Alright. Questions? Tak ada question? Tahu belaka? Boleh tanya dalam exam. Bosan lah tak ada soalan ni. Aduh. Ke tak faham belaka? Sama dia kalau tak ada soalan ni, sama ada tak faham. Ataupun...
Okay, Doktor, satu soalan, Doktor. Satu soalan.
Okay, alright.
Semua premature baby, we need to admit in NICU ke? Or...
No. Depend on the gestation. If the baby is born 35 weeks and above, good birth weight, then tak payah admit. Tapi less than 35 weeks kita admit. Sebab apa less than 35 weeks kita admit? Sebab as mentioned before tadi, sucking stimulation, sucking reflex appears 35 weeks and above. As early as 34 weeks lah. So sucking reflex appears 34 to 35 weeks. So walaupun dia good birth weight, tapi dia 34 weeks, sometimes you need to admit. Sebab sucking dia tak bagus. You nak kena assess sucking dia. Kan? Surfactant production. Betul, dia begins at 24 weeks. Tapi usually, more surfactants is after 34 weeks period of gestation. Before 34 weeks, dia akan ada surfactant insufficiency. Dia akan ada surfactant deficient. So surfactant tak cukup. After 34 weeks, baru surfactant dia okay. Before 34 weeks, minimal surfactant production. So you may need to admit. So generally, the rule is less than 34 weeks, memang confirm kena admit. After 34 weeks, depend on the weight. Okay. Lagi soalan? Tak ada? Okay lah, cukup lah. Alright, fine. I think that's it. I also need to see one of the patient. Okay, alright. I think that's it. Let's end our session here with tasbih kafarah and suratul Asr. Assalamualaikum warahmatullahi wabarakatuh. Bila your exam lah? Exam bila exam?
3 bulan 1.
Berapa bulan?
3 dan 4 bulan 1.
Tak lama dah lah. Okay lah, alright. Okay, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Okay.
Thank you so much, Doctor.
Enter the